Hello, greetings from Greece, and this is a very interesting management of a complication. As you can see here, this cataract surgery did not go well. It was vitreous loss. Surgeon decided to place a posterior chamber intraocular lens, but as you can see here, there's a significant amount of residual cortex left, which was attempted to be cleared with YAG laser. As you can see, most of the YAG spots ended up on the IOL. So we're compelled here to manage this case either by exchanging the IOL, or as you will see in this case, going in, and this is an operative view of this 72-year-old female, who, by the way, had hand motion vision at this point after a relatively simple cataract procedure. So first, we'll try and establish the stability of the posterior chamber IOL. After pushing this, you can see here pushing in the IOL, securing that there's enough capsule support, and then using iris hooks to further investigate the good position of the lens, and the lens is in good position. There's good support. It has been placed on top of the anterior capsulotomy. So as you can see here, we'll go in with a second iris hook and try and establish the stability of the lens, even at the edges of the IOL, and also make sure on how much vitreous is present. You can see this is a three-piece IOL with Prolene haptics, and we chose to go the retina route, the vitreous route. This is a 25 gauge trocar utilizing the Constellation system by Alcon. We're going to go in at 3.5 millimeters first sideways and then vertically towards the center of the eye in order to create a watertight wound. And this will be our irrigation. By the way, this is done under peribulbar anesthesia, so it's completely painless for the patient. We perform this procedure with the guidance of our retina surgeons in our practice, but this is performed by an anterior segment surgeon. And this is the irrigation fitting in the 25 gauge trocar. That was done at the 5 o'clock position, and now we're going to go on top at the 10 o'clock position, again using the ruler to establish the 3.5 millimeters, and the second trocar will go here. Again, first invade the scleral and the conjunctiva sideways. As you can see here, we're grasping the conjunctiva with the forceps in order to create a wound of the conjunctiva that will not be over the scleral wound, thus reducing the possibility of a conduit from the vitreous cavity to the ocular surface. So the second trocar goes into place. Special attention here is taken not to invade the suprachoroidal space, which would create a significant application with the choroidal detachment. So the 25 gauge vitrectomy probe is placed here. The Constellation gives us the ability on working with thousands of cuts, and as you can see here, an extremely stable posterior chamber. You can see also and appreciate the amount of residual cortex left behind. So we'll perform a very thorough vitrectomy. Unfortunately, we did not have an operative report for the initial procedure of the cataract surgery done elsewhere to establish whether or not there was nucleus fragments sunk in the vitreous cavity during the procedure. So we're going to perform a generous partial planar vitrectomy and try and visualize the posterior pole and make sure that there is not a nuclear fragment present in the posterior cavity. So meticulous vitrectomy. Again, the impressive part is the ease for an anterior segment surgeon. This is just like doing bimanual irrigation aspiration. Of course, special attention is taken to remain on the anterior part of the posterior pole, and as you can see here, thorovitrectomy, cutting into the most of the vitreous present in the vitreous cavity, and in order to secure thorough vitreous removal and all cortical aspects removal. We'll use the iris hooks we saw in the beginning of this procedure to also investigate the periphery of the IOL. The pupil was kept on purpose undilated in order to reduce the amount of vitreous that would invade the anterior chamber. And here we're removing the vitreous from the periphery of the posterior part of the intraocular lens, and as I mentioned before, an iris hook used here to expose more of the residual cortex left behind in this case. So a very generous pars plana approach to establishing a clear optical plane for this patient. Considering the age of the patient and the amount of preoperative astigmatism, we decided not to exchange the lens and retain the same lens, hoping that the IOL calculation would have been correct. So the vitrector probe, 25 gauge probe, is removed, and now the trocar will be removed as well. As you can see here, grasped with the 0.12 forceps. And this is the part where the trocar is removed. And then pressure applied to the scleral tunnel created, and as you can see, it is immediately watertight. The irrigation is on, so if there was a significant leak from the scleral tunnel, the conjunctiva would have bloated. Very little bleeding, as you can see here. We'll continue with a little bit of pressure, and we will then direct our attention to the initial trocar with the irrigation, and this is where the irrigation probe comes out, and the second trocar will be removed as well. So very little leakage, again pressure on the scleral tunnel and the overlying conjunctiva in order to attain a watertight wound in this second paracentesis as well. And essentially, the procedure is over. This is a procedure under 15 minutes, and the patient was placed on topical moxifloxacin and a steroid antibiotic combination, chloramphenicol and 0.1% dexamethasone solution. For several weeks, we're irrigating here the anterior chamber, and this is the patient almost a month later. You can see a tug of vitreous creating this correctopia connected to the initial cataract wound. We probably missed this during the initial procedure. We'll show you here a little bit more detail. This vitreous band, it is not directed to the clear corneal wounds we created for inspection of the IOL and the iris. So in order to retain a closed system, we will go to our YAG laser. You can see here the YAG settings, and then aim a little bit anterior to the iris to break this vitreous band with YAG laser. Besides the aesthetic part of correcting this subtle complication, pushing on the iris may create enough inflammatory component to create chronic macular edema in these patients. Although none had been established in this 1 month follow-up of the patient, you can see here how after a few careful shots with the YAG laser, the correctopia is resolved. The pupil achieves again a round configuration, and thus reducing the chance that CME may result from this complication. Well, I hope you found this presentation interesting, and thanks very much for your attention.